So I know I wear a lot of hats as a fire chief, but I definitely don't work for UCLA. It's Todd Legasic from UCLA and Tony Coppolino, the fire chief in the city of Fountain Valley. That's okay. I'm here representing the Orange County pilot study that the Orange County Fire Chiefs Association is sponsoring. And I'm here to tell you, it looks like there's a lot of interest in community paramedic programs. I can tell you, I'll save you a lot of time. You can just pack up. It's a piece of cake. There's no issues with IRBs. Trying to get the labor group on board is a piece of cake. And funding the programs, there's plenty of money flowing out there, so you can just go home right now. It's easy. In all seriousness, it's the first step, and I've heard this talked about a lot already, but it's really collaboration. And it's one of the first things that we did is, if I can go back 3.5 years or so and paint a picture, sitting in an EMS meeting next to the division chief of EMS in Newport Beach, and she reached over and she says, "Hey, Chief, you know, there's this community paramedic pilot study. What do you think?" "Well, I don't know, what's it all about?" And she showed it to me, and we went down the list of the different options that we could look at, and we're like, alternate destination? That's a piece of cake. It sounds like specialty center to me. Let's do it. Somebody better give me a degree when this is over for this, because I had IRB. What is that? I didn't even know what it meant. I remember sitting at the first meeting under the table typing in "what's IRB" on my phone. So there's a lot to this. It's very, very complicated. There's a lot of regulations. Funding is an issue. And I'm just going to kind of go through and gloss over some of the things that we learned and some of the things that we went through. So the Orange County pilot study ultimately asked this question: can experienced paramedics with alternate destination training properly evaluate, make appropriate disposition recommendations, and perform an informed consent process for potentially low acuity patients? So I'm going to come back to that, but just remember that was ultimately what we set out to answer. And the 3 fire departments that are participating in this is Fountain Valley, Huntington Beach, and Newport Beach. We serve a total community of about 325,000 people. And as we went through this, we cored it down, and we wanted to look at 4 primary impressions. So we looked at 4 primary impressions: isolated closed extremity injuries, lacerations with controlled bleeding, soft tissue injury with or infection, and isolated fever or cough. We used these because we felt like these were fairly low acuity type problems. These are things that we've recognized over the years that we really didn't feel like these patients really needed care at an emergency department and could go to an urgent care to receive care. So as we got started, we put together a training program, and we initially trained 24 paramedics in a 16-hour class. And about 12 of that is how to interact with the patient, how to triage the patient. But really, 4 of it with really in-depth training was on the consent process. As we went along, we realized we didn't have enough contact. That was one of the issues that we recognized, is there wasn't enough alternate destination medics in the field making contact with patients to make our catchment basin large enough to catch these patients. So we increased our paramedics an additional 25 ADPs just recently. One of the gentlemen in the previous panel said, "You don't mess with the IRB." That is true, very true. And you wouldn't think that training 25 more ADPs and putting them into the system would be a big deal. It is when you start talking with IRB. So we had to go back and resubmit for the upgrade through IRB, which isn't that big of a deal, but they don't realize we're on time constraints, and this stuff just doesn't happen overnight. It took almost 2 months to get through that process. So it is a big deal. The education part of it, I kind of alluded to already, but when you talk about other pilot studies, and one of the things that was really unique to this pilot study is the paramedics are consenting these folks in the field. In past studies, at least in Orange County, that consent process has generally happened through a physician. In our study, that's been happening through the paramedics. And it's actually gone very well. But we spent at least a solid 4 hours of initial training and then retraining on just that process. Some of the demographics of people that we've seen, and it's kind of proven to the demographics in most of the patients that we see outside of the AD pilot study. 87% of them are English speaking, 2.6 Spanish, and it continues to go on. Same thing with our age demographics, and it again aligns with the type of patients that we see normally. We have a block of that 18 to 30, and then the largest block of patients, which is our 55 and older, which is very in line with the patients that we're seeing outside the pilot study. And I'm going to skip past this, get to my notes here. The one thing on this slide is I will point out that our total, and I'm going to come back to this 115 number here shortly, but that's what our paramedics in the field deemed appropriate. This is just some of the types of injuries and what their outcome was, whether they were transported to a UCC and or an ED. And I don't want to get too far into this because I want to allow for questions and the other presenters, but I have our primary researcher here, Dr. Schlesinger, and she'd be happy to dive into this more and give you a very thorough explanation of what a lot of this means. This is really the important stuff for me anyways, our primary outcome. And when you look at this slide, it kind of tells the story. In this 9-month period, we looked at a little better than 21,000 patients. The people that we looked at with the primary impressions, with our eligible primary impressions, were almost 2,000 people. And then the people that our alternate destination medics looked at and deemed appropriate were 659. Appropriate because of their PIs. Now, as you continue to go down the list of can they actually be appropriate and go to a UCC, we get back to that 115 that I mentioned. And then it continues to scale down, and we offered enrollment to 39. So how do you get from 115 to 39? We talked earlier about the operating hours of the UCCs. That was one of our biggest hurdles because typically they're a 9 to 5 type operation. And we know that these emergencies just don't happen between 9 and 5. They happen 24 hours a day, 365 days of the week. So that's a bit of a hurdle. But I think as things evolved, as again, one of the gentlemen alluded to in the earlier panel, we're kind of back to the paramedic program when it first started and we only looked at cardiac events and trauma. Well, it's kind of the same thing with here. We have to be a little bit patient and let this play out and let it evolve. So after the patients were offered enrollment, we actually came up with 24 enrolled patients in our study in Orange County. And with that, some of the secondary outcomes that we've come up with, because we didn't just ask questions pertinent to the specific study, we wanted to find out some of the satisfaction as well. And of those 24, we found out because we went back and we did phone follow-up within 96 hours. And we did that to find out, again, kind of more information and what the patients, or how they felt about the program. So we found that 13 of the 24 actually visited another medical provider other than going back to the emergency department. So I think what's really important here, and you look at this as a success, because the next line there, 10 of those 13 actually went to their own primary physician. So one, we kept a patient of low acuity and out of the emergency department, got them appropriate care, got them safe care, and then ultimately at the end of the day, they were followed up with their own physician. So to me, that's a success. They stated that 86.5% of them they were very confident in the paramedics and the service that they offered. 100% of them said they had satisfaction with the alternate destination concept and or program. So that, again, is a big winner for us. And when you look at turnaround time, because some say, well, this adds a lot of extended time on scene, what we found through our data is it was only extended 9 minutes. And essentially, it was really the 9-minute extension was, that's kind of what it took to go through the consenting process. So that's where that 9 minutes came from. I think some other things that we weren't able to get on the slide here that become important to talk about and make sure that we all recognize is we really chose this specific type of community paramedic pilot study because we realized that there's no added cost. To do this particular program, we're using the medics that are in the field that are already assigned to the fire department. We don't take medics out of their assignment and specialize detail over here. We're running that call anyways. So really the way we kind of core it down is we just see the urgent care as a form of a specialty center. So it's similar to your stroke centers, it's similar to your cardiac centers. The UCC is just another specialty center. And once the paramedic deems that this patient is appropriate to go to the UCC, it's just giving the patient another choice. It's giving them an option. And it's giving them an option to, one, get appropriate care safely in a setting that's gonna work for them. We had a couple of cases in which the patients signed AMA and they went POV. Guess where they went? The same urgent care that we would have transported them to. So when you say the numbers are low a little bit because we're dealing with we're dealing with low acuity type medical problems that some call 911 because they just want to get another medical opinion on, am I really sick? Am I going to die right now? Or can I just go in my car and go seek medical care how I choose to? So that's some of the reason we found for some of our low numbers as well. Ultimately, I think what we aim for is to align with the Institute for Healthcare and also with the Healthcare Foundation, as I heard earlier, is to really get the right patient to the right place, do it at the right cost, and then do it within the right amount of time. So far, we've seen that is happening. I think that you have to look at the full picture, not just look at, we've only transported 24. I think you go back to how I originally started and you say, what our original question was, can paramedics triage people in the field and get them to an appropriate place safely? So far, we found that yes, they can. So with that, I'll close and then I'd be happy to take questions after everybody else is finished.
Good morning, everyone. My name is Todd Legasic. I am the director of the UCLA Center for Pre-Hospital Care. I want to thank Lou Meyer and Dr. Backer, Sandra Shuri, for your vision and support on this project. I think we're really at the tip of the iceberg right now in what's possible in using fire departments and ambulance-based EMS providers to meet some of the unmet needs in our community. We had two projects at UCLA. Dr. Ottman talked about the first one. This is the Alternate Transport Project, and our partners are Glendale Fire Department and Santa Monica Fire Department. We had 3 hospitals affiliated with us, not to mention UCLA, 5 urgent care centers. The unions were both on board at the fire departments, and we were quite pleased with the level of partnerships that we had and still have. Not unlike many of the urban fire departments and EMS systems, we're all encountered with the burden of overuse, frequent 911 callers, transports to the ED, wait times, et cetera. What was interesting about this is UCLA's role was really as a catalyst for the providers in our community. And when we went out and began talking with some of the fire chiefs, they recognized that they wanted to do something different. We had 2 very progressive fire chiefs. They've since rotated into other departments, but have been replaced by fire chiefs who've actually supported the projects. With their high call volume, 12 and 14,000 a year, respectively, they knew they wanted to do something and engaged in the project. So the description of the program, not unlike Tony's program, we used an existing system. Paramedic providers would respond to a 911 call. If a patient met criteria, which I'll talk about in a second, they were offered a consent, an informed consent to take them to an urgent care center. That transport was then conducted by either an ambulance operator group in one department or a contracted ambulance transport provider in another, and they would take them to the urgent care center. We had a very conservative patient care criteria. I think, as Dr. Backer said, there was quite a bit of alignment in what was included across the different pilots for acceptance into the study. Basically, it really comes down to isolated extremity injuries, soft tissue injuries, cold and cough for patients greater than 18 years of age and less than 70. They were transported to urgent care centers that were then approved by the LA County Department of Health Services EMS agency. Some of the key criteria for that is that they had to have a physician present, that they had the capacity, and they were willing to take all comers with regard of the ability to pay. And which seems maybe small, but that's kind of daunting if you're an urgent care center and you survive based on the patients that are coming in. So for them to agree to that, that was a pretty big commitment, as well as the fire departments willing to risk their transport fee that they may or may not get in taking the patient there. So we were pleased with that level of commitment and support by them. What worked? We had great commitment by all partners. It was a real partnership with the LA County EMS agency, with the chief of EMS, John Talmos, and the director, Kathy Chittister. I think it was working at a new level. We've always enjoyed that relationship, and I think we've been able to foster it at a new level. The training, the overall training, the core training that was involved, I thought went extremely well. The alternate transport training, where we focused on training every fire department member in this particular project, as well as our ambulance providers, we thought went quite well. We too had regular meetings like Dr. Rotman did to keep things on track and to make sure that we were moving through problems effectively. Unfortunately, one of our partners is closing their participation in the project. Santa Monica continues to be involved, and we're looking forward to working with them. I think in Dr. Kaufman's presentation, she presented some of the data. The numbers overall are very low. You would think that with the amount of low acuity calls that are out there that we'd be able to capture more. We, like Tony, had the same experience that many of these occur after hours. There's limited hours of operation for the urgent care centers. And quite honestly, I think that the paramedics did a really very good job at being conservative in the application of the protocol. So if there were any question, then they would actually just take them to the ED. And I think that worked out. We did have some patients who consented. We got them to the ED. They realized that there was not narcotics available, and we just continued their transport to the ED. We had a couple of equipment issues at the urgent care center, one with an eye injury that needed to more appropriately be evaluated in an ED, another one with the X-ray machine that had gone down. One chest pain patient, but didn't present as chest pain. It was actually a nausea and vomiting call at a local fast food restaurant. And the patient met all the criteria, age and vitals and what have you. There was no concerns there. The patient consented, went to the urgent care center. The physician there actually just had a hunch, did an EKG, came out normal. Everything seemed fine, but thought, you know what, I just got a hunch here, and she requested that patient be transported to the ED, and he was cared for there. So Lots to learn. We're still at it. We're actually pulling another group together next week in our Santa Monica community to figure out how we can best tackle the low number of calls that we're getting consented into this project. I'm joined here by Captain Matt Hill, who's the community paramedic for Santa Monica. He was the EMS coordinator, now is rotated back out into the field and could probably address some of what that consent process looks like. The patient consent is long and it's detailed. It's been one of the big rate limiters of research in EMS in general. No shocking surprise to anyone who does research. And we've not been able to tackle that. It's something that we're going to have to really address to be able to move more effectively in getting some better data and getting people enrolled into the projects. We have a short 8-page consent form at UCLA. 4 pages of informed consent, 4 pages of HIPAA. It's 8 pages in total when you take electronic PCRs and the movement into the electronic arena, and then you have to physically have paperwork on hand. It contributes to just some of the challenges that we have there. So with that, I think I'll conclude this part of the presentation, and we'll wait for some question and answers after the next one. Thank you.
My name is Mary Murphy. I'm the EMS manager for the city of Carlsbad. I came to this project after it had already started. I started in February with them, and so the project was already underway, and they'd already had their 2 patients. It's not my fault. It's nothing to do with the Irish or the last name. So we have a long list of exclusion criteria which make perfect sense, with the exception of 2 things that were added after the study commenced. One was that any patient with nausea, chief complaint of nausea, couldn't be taken to an urgent care. And the other was that anybody who was over the age of 65, and that was in relation to a Medicare ruling from Kaiser. So when this project started, there was a lot of initial interest from local providers and hospitals, and then that quickly evaporated, and there was a lot of concern that we would be taking patients to another facility. Kaiser was the one agency that was very pro being involved, and they are our IRB sponsors for our project. And so we are limited to just Kaiser patients. Just Kaiser patients who are under the age of 65, who don't have nausea, and all the other 10 exclusion criteria. And so we started off great. We had 2 patients within the first month, but a huge issue, and we look at both patients who could have been enrolled and those that couldn't be enrolled secondary to insurance, and we definitely see 1 to 2 patients a month that we're missing. And we can speak and remedy that with the paramedics, but the issue is if you don't do it often enough, you don't think to do it. And so we're really struggling with a low volume that then starts to beget a lower volume. And so that's been a big struggle for us. Currently, we have now people in the community who have improved their interest and are back talking to us and want to see if we can expand our IRB despite everybody's warning not to do so. And we are very pro as an agency, community paramedicine. We are very committed to continuing the program. Our fire chief is very supportive, and we will be engaging with conversations with some of our local hospital systems to see if we can grow this program and if we can be more inclusive for our community members. When we look at those that are Kaiser patients who fall outside of the why they're not being transported, there are 3 major issues. One is hours of operation. They're not open 24 hours a day. 2 is they're over 65. And 3 is they have nausea as a chief complaint. So we do have people that just don't make it because when you look at the chart, they clearly had behavioral issues, or there was substance abuse, or there's more to the story than the first appearance. But we feel that there's an issue with our current exclusion criteria. So hopefully that'll change and we'll grow the program. We're still committed to being part of it. And yeah, I'll take any questions along with everybody else when you are. Thanks.
Okay, we're ready for questions for this panel.
Thanks so much. Mike Luzak from the Community Paramedicine Advisory Committee. For the Orange County data, when you show the data recapitulation slide, if I'm not sure I was understanding it correctly, there was a column that said admits, and it was reflected the number 3 in the admit column. Can you address what that means? Were patients admitted to the hospital?
I think the best person to answer that question is our researcher, Dr. Schlesinger.
So we did something in Orange County that the state did not ask us to do, which is we followed up from QA purposes all patients that were deemed appropriate for urgent care, regardless of what times they were seen, whether they were consentable by all of the IRB exclusions that UCI presented us with. If a trained alternate destination paramedic saw this patient and felt that this patient was appropriate for urgent care, they were included. We QA'd all of those, because our question was not, can the urgent care see these patients properly, but can our alternate destination paramedics with their training do this safely? That was our primary question. So this data actually shows all of the patients that we were able to get follow-up data, because they went to even though in Orange County, theoretical all paramedic receiving facilities should provide outcomes data to the transporting agencies, there are some that are happier to do that. It's easier to get from them than others. So these are all of the ones that went to our partner hospitals. And of these patients, these are all the 71 patients that we were able to get outcomes data from. 3 of those patients were admitted. So that's not of 24 people that were enrolled. That is of 71 patients altogether that were transported, that were considered to be appropriate for urgent care. 2 of those patients, I will tell you, one of those patients was in fact an urgent care, let me put this back. 2 of them were actually, and there's a little bit of a problem with this data, because if you see this UCC to ED, that means patients, so 4 of the patients who actually initially went to UCC were either retransported or were call continued. One of those patients falls into this musculoskeletal trauma one, and they were a knee pain that ended up being a hip fracture. And unfortunately, as emergency physicians, we know sometimes that happens. Our paramedics have been trained in it, but this one was missed. But of the other 2, these were patients, actually one other hip fracture, and that was also a knee pain, and a fever cough that was admitted for observation. And I think their length of stay was 1 day. So essentially an observation admission.
Dr. Schlesinger, correct me if I'm wrong, but I believe those patients were not transported to UCCs. Those patients were transported to
directly
EDs.
to the emergency
so
department.
So it could be a little bit misleading. They
Yes.
were not UCC patients.
No. Only one patient who went to a UCC was at any point and was consented for enrollment was admitted. And that was, again, this knee pain that ended up being a hip fracture and a cold hip.
So I guess I'd like your opinion as to whether going forward, if we open up, if we're able to open up mobile integrated health in California, is this a viable concept, and is it an issue? If it is, what has to change? Is it needing better standards for the receiving facilities, or is it a more expansive, getting rid of the kind of excessive consent form, the oppressive consent form, and expanding the list of who can be taken to these, what kinds of cases can be taken to the facilities?
So I'll take the first swing at that. I think the biggest issue with this is it just needs to become more mainstream. I think that when you look at the medics that are out there practicing, have been trained as an AD, it's on the forefront of their mind. It's a small geographic area that we're testing this in. And you mentioned the consent. That is a long process. As Todd stated, our consent is very similar. It's 8 pages long. So it becomes a little bit daunting. I think that when you look at the healthcare organizations, they're very interested in this. They want to get the right patient to the right place. There's a financial gain for them at some point. If we can help them in the field by triaging the people to the right place and getting there initially instead of receiving care at an emergency department that's going to cost 3 times more than what it could cost at a UCC, but it's appropriate, safe care. I think it's absolutely something we should continue with. It's just something that needs to be mainstreamed more. It's something that's not on the forefront of everybody's mind. And as we mainstream it more, we might be able to fix some of these issues with the hours of operation of the UCCs. They might be more willing to stay open longer because they know there's more opportunity to receive patients that could have been triaged from a 911 call.
And just to add to what Chief's saying, the biggest thing is the parameters. The parameters are very, very strict. And when we're assessing these patients, we have to remember that these are all low acuity patients. So more oftentimes than not, we're actually talking them out of going to the emergency room. I mean, these are patients with, a sprained ankle. So that's someone who would be eligible to go to an urgent care, but we're not going to say you need to go into urgent care. Instead, we're going to say, you know what, you have a sprained ankle, maybe the best thing to do is stay home, ice it. And that's what's happening a lot with us. We aren't transporting these low acuity patients regardless. And so if the parameters were loosened a little bit, I think you would get a wider variety of patients in there. For instance, if being pregnant, you cannot go to urgent care. However, if, like, let's say my wife is pregnant and she has a laceration on her arm, we're going to go to urgent care. But based on these parameters, we can't transport those patients to an urgent care. So if the parameters were loosened, if the hours were obviously widened up a little bit, and in Santa Monica, we have as it's no secret, we have a very large homeless population. And a lot of those homeless individuals are ETOH, or intoxicated. If they're intoxicated, they can't go to an urgent care. So, but the same token, these are very, very low acuity patients, whether it's, they slipped, they fell, they sprained their wrist, sprained their ankle. If we even suspect ETOH, we're not going to take them to an urgent care. And like Todd was saying earlier, our medics always err on the side of caution. And no one wants, to be that medic who transported a patient to an urgent care who should have gone to an emergency room. So there are a lot of things that I think could be done. Do you ask if we think it should be continued? Absolutely, because we have to figure out something to do, and it potentially could take a lot of pressure off of the emergency room. Obviously, there are a lot of dominoes that have to fall in order for that to happen. It may not affect us directly, but indirectly, it will benefit, I think, everyone involved.
Just in follow-up to that, hi. What about the expectation of the patient? They dial 911, and they may have in their mindset may be, I'm calling you because I'm going to go to the emergency department. And then they're presented with another option. So it seems that you have to actually turn that 180 degrees for them to say, oh, I don't need to go to the hospital. I could go here instead. And I wonder how much of a roadblock that is for a program like this, to try to change the perception of the community that this is another arm of the 911 system and that this is available to you. I don't know how much that's a factor. It's hard for me, I think, to try to evaluate what that is. The other thing is, of course, this business with the consent. If we ever get to the point where this is no longer a study, when you give permission for iTunes to download something on your computer, you click agree and you're done. That's shorter than probably what we have to do to get a consent form done for these patients. So there are things in the way, I think. I'm not sure how you get around it when you're sort of in the midst of a pilot project. That, to me, is the creative piece.
Yeah, that's definitely an issue. Being back at the station, being away from the paramedic coordinator position, I've actually come across that. It's similar. I make an example, like it's purchasing a house. Like, people get very nervous signing that many papers. And I've had people say, you know what, never mind, how about we just go to the emergency room so we don't enroll them. And it's very daunting for people. Anytime you're signing your life away, literally, it makes people nervous. And so if the consent process wasn't a consent process anymore, I think it would be a lot easier, because if we could say, hey, you know what, we can take you to an urgent care instead of the ER. Now in Santa Monica, it was a little bit different because we did have 2 hospitals in the area, and we don't necessarily have catchment areas, but because one hospital was participating and the other one wasn't, if someone said they wanted to go to the other hospital, we could not offer the study to them. So that kind of put a damper on our numbers big time, because some people prefer different hospitals. And so I think if all around, if it was just a third place we could transport to, I think it would be a lot easier and we would get a lot more patients enrolled.
I think if I can just add something, then I want to give Dr. Schlesinger a moment because she's raising her hand back there. But to your point, I think giving people a choice, right? And once again, you go back to that mainstream, once they understand, they call 911 because they want someone to come out and tell me, am I going to die or am I going to be okay? And once we establish that, and you say, well, you've got this issue and you've got choices now. You can go to the emergency department still if you'd like to, but we have this other alternative here for you that you can get safe, quality care at. And I think that's what really drove it home for us, is to be able to give people a choice of where they can receive their care. And then we actually had a couple of cases where the gentleman talked about the sprained ankle case, and they're just going to get in their car and go by themselves. We had cases where they said they would have done that, but they couldn't, because they couldn't ambulate themselves in their home by alone. So they don't really want to go to the ED. They want to go where they can, go to the urgent care where they would have taken themselves anyway. We had a couple specifically tell us, I would get up and I would drive myself to the urgent care if I could, but I can't. So now they have a choice and they can still go to the urgent care through the 911 system. Dr. Schlesinger, do you have a...
And also, I just want to say, as UCI's representative, we approach this really as a research project. And one of the things that we did, again, outside of the pilot, is we said we have a actual population of people who we have, from the beginning, have said of lower acuity. Let's see why these patients called 911. So on our phone follow-up survey, we actually have a question, and there are no validated questions on this, but there was one small study in the 80s, actually one of our researchers had done in New York, so we used similar options to say, why did you call 911? On these patients that we know, we've already decided they were low acuity. And what we found, that there are a variety of reasons, but the 2 major reasons were, 1, I was concerned that I might have a life-threatening event, and 2, that I wanted specifically a paramedic to come and evaluate me and give me their opinion. And in these were our 2 major findings. So what we're finding is not necessarily I'm calling because I want you, and that was one of our options. I called because I wanted to be transported to an emergency department. And that in general was not a response of these low acuity patients. What they wanted to know was, do I need to go? And currently our system is structured to say, I called you, you came, and you told me I needed to go because you took me there. And now we're giving them a choice, as Chief Coppolino said. And many people, when offered this choice, either say, yeah, I will take that choice, or they will say, you know what, I have a third choice. Now that you have essentially given me your impression that this isn't life-threatening, my third choice is I have a family member who will take me. And people do pursue those options.
And can I just say, just one last thing? I think that as an agency and as an industry that cares for people, I think we need to have we need to be honest with patients about cost. I think that we have no problem telling people what an ambulance transport costs them. And I think there are a lot of people who are very taken aback when they realize what the cost is. And that should be something that they make an informed consent on. I'm lucky to have a fire chief who's will tell you upfront that he considers this not-for-profit. And we have the ability to say that, but that's with his support. But we do absolutely fully inform our patients of all their options, including the cost of making the decision they're making.
I have a quick question about, again, the source of the call. Here in San Diego, I supervise the San Diego Fire Communications Center, and we have a lot of third-party calls. somebody calls on behalf of somebody. Do you have any idea how often it's not the person themselves that are calling for the problem, it's really somebody else sees somebody and says, I'm going to get you some help. And so that really dilutes the specificity from the get-go of whether 911 is needed or not, because it's a kind of a concerned person who calls. For these alternate transportations, do you have any idea how many people actually were first-party, second-party, third-party callers?
We don't, and that was at Santa Monica and Glendale Fire Department, but it would not have changed anything in the particular response that we had. We were sending paramedics to every call anyways, in that particular case.
I don't believe that we do either in Orange County.
Just a quick question. Have the providers noticed any reduction in calls to the urgent cares? Because I know that that's something they'll do when they have a patient they're not sure what to do with, and they'll call us to pick them up and take them to the ER.
That's a good question. It's funny you asked that. Yes, there has been a reduction in calls to the urgent care, and I think it's the weird part is I actually picked up a patient from the urgent care on Sunday. So, but other than that, the calls have dwindled, and I would attribute it to a few things. Number one, I feel the staff there they're very competent, and they are very comfortable with their skills. They handle what they can handle, and what they can't handle, they will call us. Now, with that being said, they did hire some extra doctors to kind of get ready for this pilot program, and they are supposed to only have one, but they've kind of gone above and beyond, and they have usually just 2 there at a minimum, sometimes 3. But they have been great, and yes, the calls have dwindled. The one that I did pick up, it was a 3rd-degree heart block, and they just said, get this person out of here. You need to go to the ER. But they are great, and I think that as this pilot program goes on, they're going to get more and more comfortable dealing with 911 calls, and that's why I think it could benefit everyone if we get them more on board.
I would echo that, as I see Lou trying to cut me off here. But I think that what's important, and I think most people in this room realize that, is if you say emergency department, there's an expectation of a level of care in an emergency department. When you say UCC, it's A to Z, except for the ones that are participating in the pilot studies, because I know in Orange County, our medical director outlined specifically what they had to be capable of. So we know the capacity of the UCCs that we go to, but to blanket them and say that they're the same as the UCC, in some cases right next door, is really not fair, because the UCCs we're going to have guaranteed us a certain level of care so that we have a comfort, so that we know when we take patients there, one, it's safe and they're going to get the appropriate care from that facility. But there is a vast difference in urgent cares.
Okay. So that was a definite productive conversation, and I understand the concern about consent forms. I would like to let folks know that Gloria Robertson from the OSHPD is sitting in the audience, but the consent form itself is a statutory requirement under OSHPD, so it's not something we can just, change. What probably made it more complicated was when the requirement for an IRB was yeah. So when you needed the IRB is the one who said what your consent form was going to look like, and each area got a different response from the IRB on how in-depth their consent forms are to go. But Gloria, I wanted to thank you for taking the time to come down and listen to the works of the program that you oversee for OSHPD.